morning, everybody, or good afternoon, I should say, 12:30 here in Canberra. Leanne Wells here. I'm accompanied by Joe Root, our policy manager. Welcome to our Budget 2017 briefing for members, stakeholders and consumer representatives. We've got a series of slides we'll take you through this morning or this afternoon. We've really headed our presentation Budget 2017 Restoration, Not Reform, because it is very much a restorative budget, we think, both in terms of health sector stakeholder confidence in the government's directions in health policy, but there are some very key areas of reform that we still think we're focusing on, and we'll talk about those as we go through this morning's presentation. Just bear with us, everyone. Our flicking doesn't seem to be working. Okay, so in terms of the overall budget, we think overall it is good news. As I said, more restoration rather than reformation as a budget. There still needs to be attention to the long-term reform plan, work towards putting the Minister's National Health Plan into action. There is good news there, I think, on that front, and that we're starting to hear a coherent narrative, I suppose, from the Minister about where he sees the health agenda needing to go over the next 3 to 4 years, and he describes 3 phases that we'll go through in a moment. Certainly good to see the notion, in principle, of the Medicare Guarantee Fund to ensure that the Medicare levy goes on health, but of course total funding for Medicare and PBS goes without saying is still dependent on the availability of additional funding for tax receipts. We believe at CHF there is a need to, you'll hear us talk about the need to modernise Medicare to meet changes in the environment. What we really mean by that is that we have a Medicare system that is universal, it has all of those principles and features that we think are important, but we also have a system that was designed over 40 years ago now, and there's work to be done, we think, to look at aspects of Medicare that make it much more responsive to the types of chronic conditions and the multi-morbidity and complexity that our healthcare system is now managing and responding to. But the key highlights, I suppose, of this budget was the commitment to MBS and PBS and the universal aspects of that. The fact that the public value that is one of 4 pillars. My Health Record, we'll talk about that in a moment, and we'll talk about the lowlights as well. Importantly, there doesn't appear to be any increases in out-of-pockets for consumers and taxpayers, although there is the 0.5% increase in the Medicare levy for the NDIS. Indications are that the community are quite supportive of that from latest polling, that's a reasonable thing to do. It's a high need area, provided that the public and the consumers and the recipients can see that dollars are being spent wisely and in a well-targeted way. The other really heartening thing from our perspective is that the government isn't proceeding with many of the unlegislated budget repair measures, the so-called zombie measures from the previous budget of 2 years ago, and that certainly gives some certainty for consumers. I hope my audibility is a bit better now. I've just moved a bit closer to the microphone. So, with regard to Medicare rebates and bulk billing, I think it's been pretty resounding and welcome from everyone that we've seen a removal of the freeze, although from a consumer perspective that is slower than desirable. We'll certainly see some consumers still bearing costs in higher out-of-pocket costs, particularly for some higher cost procedures, at least until July 2019. fact that we're seeing a phased-in approach giving priority to primary health care reinforces the key role of primary health care, that domain of care, in improving health outcomes, and that's a pleasing measure. The other thing we're also very pleased to see is the continuation of the NBS review. So if we just have a look at this slide here, that's a good summary slide. So $1 billion in spending for lifting of the freeze, and you can see there the staged way in which that's going to be introduced. So starting in a fairly modest way in 2017 for bulk billing incentives for GPs only. So people will have to wait until 2018, July, for the freeze to be lifted from standard GP consultations and specialist attendances, out to 2019, 1 July 2019 for specialist procedures and allied health services, and then 2020 for targeted diagnostic imaging. So while we're going to see access to GPs start to become more affordable, and the hope that GPs are likely to continue bulk billing, particularly for low-income groups in the population, it is a slower lift than we would have desired, and many families, at least over the next 2 to 3 years, on average incomes, we still face the risk of co-payment increases they can ill afford. Other Medicare-related things, we're seeing some targeted measures for veterans' benefits. But as I said before, we're quite pleased here at CHF to see a continuation, a commitment to continue the review of the NBS and to continue the work of the Medical Services Advisory Committee. Those two really important health technology assessment processes are really important to assure taxpayers and consumers that we're getting evidence-based treatments, evidence-based healthcare, value-driven healthcare, and that we're actually systematically looking at the NBS and all of its items to address waste, to weed out obsolescence, and to free up space in the system, if you like, for newer treatments, take account of efficiencies in technology and those sorts of things. Turning to primary health care more broadly, there's been a lot of noise around the government's health care home program, and it is important to draw the distinction between that being a government program and to note that there are different types of ways of implementing patient-centred healthcare home models of care. There isn't one fixed model. There have been delays announced in the budget to the implementation of the government's program. We're not necessarily negative to that. We think it's really important to give opportunity and time to get the implementation right, to prepare practices and to prepare patients, those that are going to be involved in participating practices, 200 across the country, the time to really understand and embrace and implement that model in a way that's going to get the best learnings out of it and guarantee success. The lack of additional funding is disappointing. We would have liked to have seen the savings generated from the delay reinvested into the program or reinvested into primary health care reform. There has been some funding announced in the budget for an alternative model to be tested through a research pilot developed by the RACGP. That was a bit unexpected, but again, it does provide opportunity for innovation and scope to evaluate another model. At this stage, we do have to be open to really testing how we can make the transition to patient-centred healthcare homes in a robust way. So the more data, the more experience we can gather and learn from, the better off we'll be in making that transition. Another welcome measure was the explicit inclusion of pharmacists in the healthcare home model, and from the perspective that we want, while it's focused on the general practice setting, we do want integrated models of care, and the inclusions of workforces like practice nurses, and pharmacists are a really critical part of what's going to make these a success, we think. There's some measures around after-hours care in relation to primary health networks. That's more a reconfiguration that will see that will achieve savings rather than spending. So that's just a summary slide there that summarises the spending, $5 million and $25.6 million respectively across those two measures I was just describing, and the associated savings. So over to Jo now. We're going to cover off on medicines and pharmacy issues.
Oh, hi everybody and welcome today. The first point we're going to look at is the prescription medicines pricing. The government has finally entered into an agreement with Medicines Australia to fix prices, to take some price cuts and to give them stability. And this is one of the compacts that the Minister announced as part of the budget. The pricing that Medicines Australia agreed to is basically to cut the cost of medicines on patents, medicines that are the only one of their kind. There's no generic for them, and there's not another brand that does exactly the same thing. And they've agreed to quite significant cuts to those of 5% when they get to 10 years listing and 10% when they get past that, and also a cut once the generic becomes available. This is good news. CHF has long argued for better price disclosure and a better model of price disclosure, and we've joined with people like Stephen Duckett to say that we're paying too much for medicines in this country. So I think these measures will start to cut the cost of medicines. That'll do two things basically. It'll free some of the space up on the PBS to have new medicines available, so it will allow the government to agree, as it is committed to new listings coming from the Pharmaceutical Benefits Advisory Committee, and it will mean that up until the amount that's freed up by the pricing, there won't have to be savings found elsewhere. Obviously, if there's a lot of new medicines or they're particularly expensive and the amount that they cost exceeds the amount freed up by the price cost, then there will still have to be some savings found. But it's a really positive way of getting new medicines, once they've been approved, of actually getting funding for them, subsidisation. It also has the potential to reduce some out-of-pocket costs, as some prices will fall over time below the current co-payment. Consumers only pay a maximum of the co-payment, so if your medicine, as many of you are aware, falls under that $38.80 figure, then you only pay how much it is. And as we cut the cost of medicine, so that will give consumers a better deal in terms of reducing out of pockets. And we know from the latest AIHW data that more and more people are not filling scripts because the prescriptions are too expensive and they don't have the money. So we think this is a positive move. We also see in this agreement, and the agreement that went alongside it, which was with the Generic and Biosimilar Medicine Association, a move to increase the uptake of generics and biosimilars, and particularly biosimilars. And we're keen to say that we think the move to change the way that software deals with prescription, which pushes doctors to put in the active ingredient, so the medicine, rather than the brand name, will actually encourage people to take up generics. Again, if more people take up generics, then they're cheaper for the government to buy on PBS. They may cost the same in a co-payment, but they're cheaper for the government to buy, and that frees up money on the PBS for more medicines. The other part of this, which is an important part, is the move to increase the uptakes, particularly of biosimilars. Biologic medicines are coming onto the market quite quickly. They're very expensive. If we can increase the uptake of biosimilars as a cheaper alternative to a biologic, then that means that more people can have access to these quite revolutionary medicines. The GBMA, the generic the Generic Biological Medicines Association, is going to be given some money to pursue the work that was started under the Biosimilars Awareness Initiative, which was to try to educate prescribers and dispensers and consumers about what a biosimilar is, why they should agree to have a biosimilar, and why they should opt for that ahead of a branded medicine, a biologic. So this slide just gives you the savings. The savings are quite large at 1.8 billion, and that means 1.8 billion, hopefully, that it goes into new medicines on the PBS. And already they've committed to a 1.2 billion spend on new medicines. So that's good news, I think, for most consumers. And here we have the details about increasing the uptakes of generics. So they're looking to change the prescribing software, and they're looking to have a range of other measures that encourage both the innovative medicine section, represented by Medicines Australia, and the Generic and Biosimilar Medicines Association to work together to try to pursue this as an issue. So we might pause there and see if there's some questions.
So we do have one question. I think we may have some others coming in as well. So the first question, it relates to healthcare homes. Is there any talk of integrating dental with the healthcare home model? As far as we're aware, there's not at this stage. The healthcare home model, in terms of the government's program, is very much focused on changing the way, or bundling the way, general practice and associated services offered from the general practice setting are offered to people with complex and chronic conditions. So it basically cashes out, if you like, funding that's currently available for GP chronic disease plans into stratified payments for practices that they can use flexibly to pay for services. That's not to say, of course, that CHF isn't a strong advocate, and we work very closely with the National All
Health
Alliance to advocate for reform and change in that area. And that's also not to say that oral health isn't an important comorbidity or part of that multi-morbidity challenge that we're trying to manage, but at the moment it's currently not an explicit part of the service model. I think that's why it's important to think about the healthcare home program as being a very, very early first step and a first foray into how we can change the system and funding levers and the way care is coordinated and the way services are configured to better deal with these very issues. Work in progress.
There aren't any other questions at the moment on what we've already said, but if you've still got a question, feel free to send it in, and then we will do some other question sessions throughout or at the end of the webinar. So now we're going to move to pharmacy, which of course is a really important part of primary health care and an important part of the health system. The government has agreed to a variation to the 6th Community Pharmacy Agreement, essentially, which is the key points we're going to look at today. The Community Pharmacy Agreement, for those who don't know, is an agreement between the Pharmacy Guild and the government to set the funding for dispensing medications, wholesaling, and a whole suite of professional services from pharmacy. So what we got out of this budget was funding that we're talking about comes from the Community Pharmacy Agreement, which was signed 2 years ago. So this is funding that's being put on one side from the government, and they're now deciding how to spend it is the key issue. It looks like a move away from the evidence-based approach to new services to agreement between government and guild on the allocation across services. Part of the 6th CPA was to have a pharmacy trial program which would follow a robust evidence-based trial to get people to look at what services pharmacists could provide, to test them, and then if they came up as cost effective and showed from the evidence that they actually made a difference, then they would be rolled out over the duration of the agreement. This process has been very slow, and I think the decision was made as part of this agreement to speed things up. So basically, they've given the money, they've agreed with the Pharmacy Guild about spending the money on a suite of services, and to look at what else they can do to spend the money, and it'll be a set of services agreed between the Guild and the government. We welcomed the move to integrate community pharmacy into primary healthcare, which Leanne has already spoken about, and that's through collaboration with the healthcare homes, but also collaboration with the primary health networks. And while it's not 100% clear what that collaboration will look like, it's going to be the Guild working with the PHNs to look at how they can be seen as the primary health networks as key stakeholders, and then moving to utilise the services of pharmacy. I guess it's a bit of a shame that the whole move to put healthcare homes, to put pharmacists into relating to healthcare homes, has been through the community pharmacy or retail pharmacy model, because there are other models of actually putting GPs into general practice. And some of the other commentators in this area, as well as us, have said that this could be a bit of an opportunity lost to actually move to a more diverse set of arrangements that had the work of pharmacists sitting within the GP practice, as well as other pharmacists sitting in the community, and having both models working that would meet the total needs of the community. So I suppose we're a bit disappointed on that one. We're also disappointed to see the commitment to continuing the location rules legislation before the review of pharmacy remuneration and regulation has reported. We think it would have been better if the government had waited for that independent review to complete its work and report, and then had made decisions about what it would actually do. So here we have the where we see that they put $30 million into medication management programs in healthcare homes. They've given the Guild members, the community pharmacists, an extra $225 million, which is basically to compensate them for dropping prescriptions, which has led to a drop in their income. And as we said, they're going to have put the legislation on an ongoing basis for pharmacy location rules. It was due to end soon, so they've made sure that it continues. And there's a couple of questions, one on generic medications. Does this conversation also include the generic branding by pharmaceuticals while they also still have an active patent? Is this double dipping? Well, I think that's an interesting question. It's somewhat surprising to people who don't understand the pharmaceutical industry, which is me as well as many of you, I suspect, that many companies produce a patent, produce a medicine, an original, and produce the generic. And this is true both of generic single molecule as well as biosimilars. So they're actually marketing both. They're marketing the branded one and they're marketing a generic. I guess they decide that once it comes off patent and other people can have a generic, then they might as well produce a generic. Strictly speaking, they should really, they can't really distribute a generic while it's on patent, but I guess if it's their patent, they can do it. But it is interesting. I don't know that it's double dipping. I think it's just a business model for a pharmaceutical company to decide where it's going to get its income. They don't really get any different funding by doing both. In fact, they'll get a lower price on the PBS for a generic. And once they make a generic available, then actually it lowers the price of their innovative medicine as well. So in a sense, they could be seen to be shooting themselves in the foot. So it'll be interesting in that. There's another question about healthcare homes and allied health services involved in healthcare homes. And the question says which are involved, in particularly optometry. While we expect that allied health services will be a part of the services that people access who are in a healthcare home, the funding for the allied health services is kept completely separate from the rest of the funding. Currently, you can get a number of services, allied health services, 5 allied health services as part of the chronic care plan on the MBS, and you'll still be able to get those, and that money won't be rolled into the healthcare home money. This was argued quite strongly by allied health professionals that they wanted to keep the funding separate. We had argued that maybe there should be more services available for allied health to complement the work being done by the GPs and the practice staff, the nurses. At the moment, the government has decided to keep it at 5 for chronic care and not move it up. So that's unfortunate, but that's, as Leanne said, the healthcare home model is a very specific model. It's quite a narrow model that's just being trialled, and hopefully as the trial rolls out and we start to get a better picture of what is needed, then we can have another discussion around where allied health sits, how we might fund it, how many services people need, and who should be providing them. So I think that's on the future to-do list.
The other comment I would make on that is that, and I think that's the other really important point about the healthcare home program and its implementation, and certainly one where pretty well all stakeholders have been saying the same thing. The importance of needing to support general practices to make the change. This is a big change. It's asking them to continue to operate a current business model on top of or in addition to, or in parallel to, a new way of organising services to implement healthcare homes program. So, as Joe said, for patients, they can still access 5 allied health visits. Now, depending on the scale of the practice, the size of the practice, its model, a practice that has lots of co-located allied health providers, can often find ways, and currently do find ways of integrating allied health workforce in pretty impressive ways, even under current funding models. I know of one practice on the southeast coast of New South Wales that employs a social worker now, with outside of any sort of changes to the way general practice and allied health services are funding to help with coordination of care. So this is how the change management is going to be implemented, is going to be part of where the evaluation needs to have a good look as well. Okay, we've got another question coming in, which is a very nice segue to the next topic we wanted to talk about. What were the prevention measures included in the budget? So, prevention, there was a fair bit of fanfare earlier in the year by the Prime Minister in a National Press Club address in February, where he talked about prevention being a flagship area for this government. That's continued through. Minister Hunt's talking about prevention as being one of his 4 pillars. I think we can safely say that, we were fairly disappointed that there was a lack of significant investment in prevention in the budget, despite it being one of the pillars. So I think you can say, on the whole, it was a bit of a low light. What we saw included was piecemeal and lacking, coherent strategy. But we did see one program announced, which was a Healthy Heart initiative. So you can see there on that slide, $15 million to the National Heart Foundation to work on an initiative that promotes and encourages people to join walking groups. So its focus is very much on promoting physical activity, and there was obviously some reinvestments there, or continued investments in the no jab, no pay immunisation programs. So look, I think prevention is a work in progress, and there is commitment in Greg Hunt's forward planning to be looking more closely at that space. For CHF's part, we've advocated, along with our public health partners for a coherent, comprehensive national obesity strategy along the lines of the tobacco control measures that we've seen as being so successful in this country. Mental health. Mental health is another one of the Minister's pillars. There's been a very strong and organised mental health lobby. There's been a very strong, forward-looking, I think, report to government, and the government response made sense to the report by the National Mental Health Commission. That's laid the ground for some fairly significant change and improvement in mental health. So what we saw in the budget were some fairly targeted measures, fairly small-scale new initiatives, looking at addressing gaps in services, focusing on veterans' mental health, the gap in psychosocial support services that's been created by the move to the NDIS, and mental health for rural and regional Australians. So we'll just go to the slide there that summarises those for you. So basically we're looking to see some expansion of access to mental health services for current and former Defence members. We're seeing $80 million going into psychosocial support services for those people who are not eligible for psychosocial disability support under the NDIS. So really looking to fill that service gap. And the idea that the Commonwealth has is to leverage a co-match, if you like, from the states to the $80 million that the Commonwealth's putting on the table. So if all states play with that, then we'll be looking at more money in that pool. And then some funding to enable Australians who live in rural and regional areas to access services from psychologists and other mental health workers through telehealth. Which is a very good measure, we think, even though the funding's not overly generous. Actually, we're going to talk back to Joel on research and the research measures, but there's a question that's come in now, and it's a query about whether there's any ongoing or increased funding directed to preventing type 2 diabetes. I would say the answer to that is no. There's some targeted measures around better supporting self-management for children and teenagers with type 1 diabetes. There's the walking initiative, which you could argue is around anything that any measure or program that prevents that encourages physical activity is part of a response to preventing type 2 diabetes, but not part of the overall picture.
And it would be part of any obesity campaign would be targeted to helping reduce the incidence of type 2 diabetes, and the healthcare homes would also provide some better care of people with type 2 diabetes as one of the chronic conditions that would make you eligible to be an enrolled patient in a healthcare home. So I hope for whoever asked that question, that sort of shows it's all over the place, but nothing specific. Another part, one of Minister Hunt's pillars is research, and he's particularly interested in research. And in this budget, they announced the first round of investments from the Medical Research Future Fund, which you'll remember was set up in the 2014 budget. And many of the measures that have now become zombie measures were going to actually help fund the Medical Research Future Fund. But the government has committed to funding it. And there'll be an investment of about 65.9 million in this first year, and that will grow to 1.4 billion over the years. The first round of investments have been announced. They target, as you can see, prevention, which we've just been discussing, and particularly looking at things like health translation centres, which are going to take the research that we've done into prevention and help translate it into action and into initiatives and policies that will actually make a difference. I think there's most of us would agree there's little point in doing research if it doesn't then inform future developments and help lead us where we want to go. So the translation centres will make a contribution to that. The Minister has also announced that there'll be more support for clinical researchers, which I think is welcome, to build research excellence and leadership. And this is to help maintain and keep our clinical researchers in Australia, and to help improve clinical trials, and which in turn will accelerate efforts to get treatment. So I think that's an important set of initiatives, and there will be some money for breakthrough research investments. When this fund was first announced, it was very much seen as funding cures, and I think the current Minister's approach is to have a much more complex arrangement, seeing that all the parts of research have to come together, and breakthrough research investments really are important. And, you know, flagging things like addressing health challenges like antimicrobial resistance, you know, where we have diseases that are not responsive to our antibiotics anymore, and what are we going to do? And that's really a major challenge that is facing all of us in Australia and in the world, and we need to play our part in finding a way of dealing with such a challenge. So this slide just basically shows you that there'll be 65.9 in the Medical Research Future Fund. There'll also be an extra 15 million for research for early intervention and prevention initiatives in mental health and well-being, which I think is important. I think it shows that it's not just looking at medicines and cutting edge of medicines, but it's actually looking at a range of research issues that can substantively improve people's quality of life. So if we don't have any more questions at the moment, we might go on to digital health. The digital health, I suppose, is seen as an enabler of getting a more efficient and modern healthcare system. You know, we all use digital means for doing our banking, shopping, everything else. So we need to get the digital health process right. And I think, you know, we have the Digital Health Agency now, which is taking responsibility for implementing the digital health strategy. The first one and the key issue for most people is the continuation of funding for the My Health Record, and the move by government to go to a rollout of the opt-out system. So everybody will have a My Health Record created for them unless they say they don't want it. And that's a big change from where we had opt-in. The trials of the opt-out showed that people, once they had the process explained to them what a My Health Record was, most importantly what benefits they could get from it, and had their concerns around privacy and the integrity of the system explained, were quite happy to have a My Health Record. And so the challenge will now be to make sure, as we say at the bottom of that, that it's not just that everybody's got one, but that everybody uses it, and that their health providers put information onto their health record. The important part about the rollout is that it needs to be tailored to specific communities, and it needs to listen to the needs of the consumers in that area. And so we were pleased in the trials that there was quite intensive consumer and community engagement. And we've certainly flagged with the government that that needs to be a key feature of the national rollout, so that we don't just tell people it's happening, and we don't just send them a letter from Medicare or Centrelink or anybody like that, but we actually explain to them what it is. And so we're very pleased to see that there is some additional funding for the continuation and expansion of My Health Record, and we think that this is the first step in a digital health strategy. Obviously, a digital health strategy has more than just My Health Record, but when we've held consumer consultations, the discussion predominantly has been about My Health Record and the need to get that right. And so I think very sensibly the government has decided this is the first cab off the rank. Let's get this one sorted out, and then we can move to a broader digital health strategy that looks at using telehealth, e-prescribing, a whole range of issues, and deals with people's concerns, and the concern about privacy and security of data is key to that. So no questions? Yes. I hope some of you are still there. So, from the previous budget, we have what we call zombie measures, which are measures which they have been in previous budgets and have never passed the Senate, and so have never been enacted, so have never come into being. And there was a whole range of zombie measures put up in an omnibus submission last year, but didn't include health. The two key ones that we were very concerned about when they were introduced, when they were flagged to be introduced in the 2014 budget, was a one-off increase in the PBS co-payments of $5 for general patients and 60 cents for concessional patients, and an increase for the safety net thresholds for PBS, so making scripts more expensive for everybody and making it that you had to get an additional number of prescriptions before you got onto the safety net. The government has finally abandoned those, and so we're fairly confident about that those won't happen now, and that means that we can plan and don't have to worry about keeping on saying get rid of it. The other one was the changes to the extended Medicare safety net, which was clearly not going to get through the Senate. I think the safety net issues are much more complex, and the extended safety net is an issue because it has quite an unusual effect, is that it benefits mainly people in high income areas. However, just changing this one part of it before you change the whole safety net was not considered a good idea, so they've got those. So overall, we think these are pluses for at least heading off some potential increases in out-of-pockets for consumers. And we also have put on this slide the decision to retain the bulk billing incentives for diagnostic imaging and pathology services. Some of you might remember that in a previous mid-year economic outlook statement, I think it was the 2016 one, 2015, it was the government announced that it was going to get rid of bulk billing incentives for diagnostic imaging and pathology services. This would have increased out-of-pocket expenses significantly for most people. Many of the diagnostic imaging services would have moved to not bulk billing, and as many of you know, the costs of diagnostic imaging services can be quite expensive, so people were looking at increased costs. Pathology services as well, most people are bulk billed for pathology services this day. We argued that these bulk billing incentives should be retained because people don't choose to go and get tests done. They get recommended by their doctors, so it's not them that's going to, they have no control over what tests they have, and it would have been hitting consumers pretty hard. So those are the zombie measures from the health. Before we move on, somebody's got a question about the My Health record, whether it was going to integrate with the hospital system. That's certainly the intention as we move to integration and try to get the systems talking to each other. It's interesting that the My Health record was actually the approval for the national rollout came through the Council of Australian Government process, which is state and territories and the Commonwealth. So the state and territories are quite keen to have the system rolled out. Clearly it won't deliver its main benefits unless it is integrated. The problem will be, in Federation, we've got 8 health systems, and then we've got the Commonwealth is trying to get something which works for all of them. But certainly it needs to have discharge summaries put on it, so that when somebody leaves hospital, their changes to their health status, their changes to their medication goes onto their health record, goes with them. Everybody who needs to see it and who the consumer has agreed can see it can see it. This would reduce confusion. It should lead to better follow-up. So we think that that's the discharge summary part of it is important. GPs would then be aware that one of their patients has been in hospital, because sometimes they're not, and then they find out after the event. So certainly the intention is to integrate it. Whether it happens, how long it takes and how it happens, I think is something that the Digital Health Agency and the state health departments are working through at the moment, and having conversations about how the two can be integrated. We've got a few other things here which we'll just go over. I'll just go to the slide very quickly. Greater choice for home-based palliative care. This was a welcome measure to increase the options for home-based palliative care. As we know, 70% of people say they want to die at home, and 70% of people die in hospital. So obviously we have a problem there. And this is a small step, but an important one, to try to start getting the balance right and supporting services and supporting families to care for somebody who's dying, so people can die at home. That's a very welcome first step. The child dental benefit schedule was, in the last budget, was going to be abolished. We and others, through the National Oral Health Alliance and many other lobby groups, have lobbied against that, and we're pleased to say that the scheme was kept, and the cap of $1,000 per person was reinstated in this budget. That was a real win for active advocacy and a very important part for children's dental health, because we know poor dental health leads to other poor health. And supporting living organ donors, important to increase the rate of increased donation and transplants, and this is a way of supporting people with extra leave, with other support mechanisms where they make the ultimate altruistic decision to donate an organ while they're still living. And this is, we have low transplant rates and low donation rates in this country, and this is seen as one measure to help improve.
Okay, thanks, Jo. Any more questions? Just keep typing those in there. We don't have any for the moment. Just a couple of wrap-up slides now from me. Just what you can see on this slide really is a summary of what Minister Hunt is describing as his 4 pillars for his National Health Plan. NBS, PBS, hospitals, prevention and mental health, and research. I don't think any of us in the consumer community would disagree with those as being important areas. They have a logic to them. That's where we need to focus. It's where we need to continue to invest. I guess what we're pleased about at CHF with regard to Minister Hunt's plan is that we've really seen a down payment, I suppose, in this budget. A budget that is restorative, a budget that has really, by taking measures to end the freeze, to take the so-called zombie measures off the table, finally and very definitely, it's sort of really levelled the field, I suppose, so that there's more headroom to start, for the government to start working with the health community on longer-term health reform. We've had 10 years of review after review, and commission report after commission report. And so while it's good and good public policy to review policy directions and to hold inquiries, and we welcomed some of Minister Hunt's predecessor, Minister Lee's reviews, as being long overdue, particularly in the pharmacy area, particularly in the private health insurance area, where we get a lot of commentary from people about the system needing to be fixed. We're also heartened by Minister Hunt's, I suppose, commitment to action across 3 stages. I'll talk about those in a moment. What we saw announced on budget night was quite an interesting approach, we thought. Took us a bit by surprise on one level, but actually when you think about it, they do fulfil a number of purposes. So what we saw the Minister announce were the fact that he's sort of underpinning his budget and future discussion with the health sector with 5 compacts. He's also talked at a budget breakfast we went to late last week about having more of these compact-style agreements in place. So basically, there are now, and they're publicly available on the department's website, 5 compacts between the government, so they're bilateral, with the RACGP, the AMA, Pharmacy Guild, Medicines Australia, and the Generic and Biosimilar Medicines Association. The reason we think they are a good thing on balance is that one of the things we asked for in our budget submission was for the government to not lift the Medicare freeze by losing the opportunity to actually obligate or put some ties around that decision. So if you have the time to have a look or have a quick glance at some of those compacts, what they actually do is obligate organisations like the RACGP and the AMA to hold up their end of the bargain in many areas, so to speak. So to promote My Health Record, and as we've always been saying at CHF, we've got to start somewhere with My Health Record. We've got to start with consumer and community confidence, absolutely, but we've also got to start with the clinical community that sees the value of its utility as well, because if GPs don't use it, it's going to fairly rapidly become quite redundant or not as high value as it could be. So that's the value we see in those compacts. And the fact that they're public means that both the government, but also, those with an interest, those with a big stake, at the end of the day, those with the biggest stake in all of this, the patients and taxpayer, can hold these organisations to a level of account for those obligations. So that's a really healthy public policy thing to do, we think, and on the whole we've welcomed them. So what we've heard Minister Hunt talk about, in the media and at the speeches he gave last week was the 3 phases. His National Health Plan being taken forward in 3 stages. So we've had the first stage being the budget. The second stage, he wants to start looking at significant changes, quote, to private health insurance, further strengthening of mental health, and having a look at, where we can, what we need to do, I suppose, to anticipate what changes, what improvements, supply side, demand side, what is the care side we can be looking at in terms of workforce development and change. And then moving forward in this 3rd phase into addressing the challenges of the next round of hospital reforms. And that's an important domain. It's obviously an area where there's big government spend, but we also think that's a big area ripe for reform. Clearly we want the Commonwealth and states to agree on a hospital system that has funding certainty and surety, but we also want to see reform in that area, and the leverage of the Commonwealth investment to be not just about more dollars for more beds. That's important, but more dollars and bilateral agreements between the states for putting in place innovative hospital avoidance programs, innovative models of integrated care, because it's one thing we hear about commonly here in New Zealand as some of our member organisations too, that often the patient experience of care is one of fragmentation, and leaving hospital and discharge can obviously be a very bad transitional care, can be a very dangerous space. So I think we will wrap it up there. We've got one final slide here as a question as well. I'll come to the question in a minute. So just the wrap up slide, what's missing, I think we've touched on this. the lowlights, or what was missing from this budget from our perspective, but heartened by Minister Hunt's parentheses around this for his third stage. Private health insurance, there were no reforms announced there, despite fairly intensive work that's been going on through the Private Health Ministerial Advisory Committee. Action on obesity in terms of a really tobacco control style public health program, not just a campaign, but a series of a multi-faceted obesity prevention action plan is missing in action. Primary healthcare reform is an area that's got huge promise, and where we need the system skewed. We know that strong performing health systems have strong primary healthcare backbone, so we need accelerated work and effort there in consultation with all stakeholders. And obviously an area that's important to us and that we included in our budget submission was we do need investment in measures that really are going to support the consumer-centred health system, and by that we mean measures that are going to support consumer involvement and participation in health decisions and health policy setting. So, investment in consumer involvement, systemic consumer involvement and voice in health technology assessment processes, investment in consumer leadership programs, support PHN so that they can work and involve consumers and communities systematically in their commissioning decisions, those sorts of things. One final question then. How can prevention be one of the 4 pillars if there's minimal to no funding provided for it? Well, I think that's the 60. I think we've answered that, and we would share that concern. And I think it obligates us all, Consumers Health Forum, to work with our members and to work with our counterparts in the Public Health Association and other organisations to really continue to advocate and try and influence and active impact on Minister Hunt's thinking around where he can go with the prevention agenda. So on that note, unless there's any more questions, and we're right on time anyway, so I think we will draw a line and call a close to our conversation. Thank you so much for joining in. Thank you for your questions. And if there are any other outstanding questions, we will answer them and post those answers up on our website or get them to you in some other way. So thank you again. Good afternoon.